بسم الله الرحمن الرحيم. الصلاة والسلام على سيدنا محمد وعلى آله وصحبه وسلم. I would like to thank the organizers for this invitation to participate in this meeting. I was given the task to talk about the brain tumor resection and seizure outcome after epilepsy surgery, which is a very important task in the field of epilepsy surgery, as many of us know that almost every fourth patient presenting for epilepsy surgery has a brain tumor. And still, the extent of surgical resection and the comprehensive management of this patient is still an area of controversy, making a contemporary issue in epilepsy surgery. Brain tumors are common causes of epilepsy in adults. Almost 1/3 of 35,000 patients per year with newly diagnosed brain tumor develop epilepsy surgery, especially if the tumor involves the cerebral hemisphere. At least 50% of those patients, they will have epilepsy. Common tumors involved are the gangliogliomas, DNET. Now, in pediatric literature, or pediatric brain tumor literature, the most common lesion is the ganglioma, and this is also found in limited adult epilepsy surgery literature. Still, ganglioma, WHO grade 1, is the most common type of brain tumor accompanied with intractable epilepsy, followed by low-grade astrocytomas and low-grade oligodendrogliomas in adults. This is data from the European Bank of Epilepsy Brain Tumors submitted to this bank, again confirming that the ganglioma are the most common cause of intractable epilepsy-associated brain tumors with early age of onset, followed by DNETs, and the astro and the oligodendrogliomas are more common at older age. This brings us to an important topic, which is the long-term epilepsy-associated tumor, or the newly defined as epileptomas. What are these? Those are tumors, the lead encompass lesions in patients investigated for a long history of intractable epilepsy. And in general, they are slow-growing tumors, cortically based, and often arise in younger age patients, and histologically, they have neuronal and glial differentiation. This is a good example of ganglioma, where you see the binucleated dysmorphic ganglioside with and it is commonly associated with focal cortical dysplasias. Epilepsy associated with lead in generally are, although they are pharmacoresistant in almost 30% of patients, they're extremely responsive to surgical treatment. It is very common to occur in the temporomesial aspect of the temporal lobe. Therefore, they are a peculiar behavior that they are involved in the complex epileptogenic network of the temporal lobe. Again, as I said, the management strategy of these tumors deserves attention, as the trend nowadays is that we don't do lesionectomy alone, but we need to do an extensive tailored resection to ensure a better seizure outcome. What is the evidence for that? We will come into that in a minute. Now, this is again data from the pool from the European epilepsy brain tumor, collecting data from 1994-2013, where there is an increased frequency of submission of cortical dysplasia, reduced submission frequency of hippocampal sclerosis, and stable submission of lead. And the interesting thing is that there is increased earlier age of onset of epilepsy surgery for lead, while during the years, while there is a static duration of epilepsy prior to epilepsy surgery in the other two lesions. So in order to understand the need for the tailored resection, one has to understand several factors, and we have to look at the several factors that influence the seizure outcome after epilepsy surgery. Namely, the histology or the nature of the tumor, the location. These are very important factors that influence the degree of the surgical resection, and subsequently, we will talk about the basic molecular level of many of these tumors in lead, and that also necessitate the extensive resection of the lesion plus the surrounding epileptogenic region. Now, in order of importance in relation to the epileptogenesis, number one is the changes in the neurotransmitter, and I'll show that in a second. The ionic changes, the subsequent hypoxemia, acidosis, the immunological and inflammatory changes, and the morphological changes. Not only within the tumor themselves, as many of these lesions, namely the ganglioma, they have intrinsic epileptogenic activity, but also in the peritumoral regions. So we'll start with the tumoral type and frequency. Glial versus non-glial, slowly growing versus rapidly growing. The slowly growing glial tumor are more epileptogenic, and the glioneural tumor are highly epileptogenic. Now, according to the WHO classification, they divide them simply into neuroglial tumor and glial tumor with common type and uncommon type. However, this classification is far too simple for the current available data, that we have a lot of new types of these lead tumors that cannot be accommodated with this classification, lead to the proposal of a new neuropathological classification looking into different histochemical immune markers that can provide further classification of these tumors, and therefore better understanding of the tumors and the arrangement of the better surgical modality. So if we look at this, now with this new immune histochemical, looking at special molecular markers in gangliomas, we can classify the gangliomas into the basic neuroepithelial tumors and the neuroepithelial tumors by having positive special markers, the CD34, positive in the BNet, while it is negative in the DNet. With also, we have some data from this basic molecular level that this this molecule can be seen intensely in some of these tumors, while we can see it also in remote areas from the tumor, suggesting satellites of the tumor, again necessitating remote from the lesion, necessitating the extensive resections. Now, these are some of the other supplementary biomarkers that helps in the differentiation of different entities of these leads. For example, you have the new N that stains the dysplastic neurons, the PS6 looking or concentrating or accumulating in the dysplastic neuron, and so forth. Now, another important concept that supports the extensive resection of brain of lead is the common occurrence of dual pathology with these tumors, particularly cortical dysplasia. Now, hippocampal sclerosis occurs in 15% of patients with ganglioma and 6% with the other tumors. And as we know, in the field of dual, or in the concept of dual pathology, the resection of both lesions gives you better seizure control. Now, the more important pathology is the cortical dysplasia, because it occurs more common with these types of tumors. It occurs in 82% in DNET and 48% of ganglioma, and it is important to remove the lesion and the surrounding cortical dysplasia to improve the seizure outcome. So we looked at the histopathology of this lesion, and as you can see, the nature of this lesion necessitate or the histopathology of this lesion necessitate not only the lesionectomy but the more extensive resection. Now, the tumor site is another important factor. The diffuse low-grade gliomas occur more in the paralimbic structures, in the insular, frontoinsular, temporal-insular, while the lead occur more commonly in the limbic structure and the temporal mesial structure, so they're actively involved in the epileptic networks. Recent data shown that in the mesial temporal lobe lesions, both the lesions and the hippocampus have a role in the epileptogenesis of these lesions, even in the absence of the MRI abnormality, and the pathological examination shows normal finding. This is the concept of the epileptogenic network. When you have a lesion in the temporal lobe, it will not only cause local epileptogenic changes, but also it will activate local or adjacent epileptogenic network and remote, and therefore the larger the resection is the better is the outcome. This cartoon shows you the connection between the mesial hippocampal structures and the mesial part of the parietal lobe to the coneus, to the preconeus, and the posterior cingulate. Again, maybe gives us an explanation why patients with lesions in the parietal lobe tend to have less seizure freedom in comparison to temporal. Looking at some of the data from the long-term surgical outcomes, gangliomas and DNETs occur more common in the mesial temporal structures. Extensive resection gives you better seizure outcome, less surgical outcome, seizure control surgical outcome was seen in this series in patients with posterior lateral temporal because of the limited resection and therefore worse seizure outcome. The important risk factor associated with poor outcome were the duration of epilepsy more than 10 years, so more secondary epileptogenesis, and therefore less and more epileptic network, the presence of remote EEG focus, and of course the failure of macroscopic resection. Now, there was a trend for better outcome for mesial temporal lobe resection. Now, moving to the basic pathophysiology or the pathology, we concentrate on the neurochemical profile affecting in the region of the tumor and in the surrounding tissue, affecting the local network and the global network. There is excessive glutamate receptor upregulation in the tumors, downregulation of the GABAergic neurotransmission. There is also involvement or alteration in the gene expression in the glial cells in these tumors with activation of the calcium permeable AMPA glutamate release increasing glioma cells. Also alteration in the ion hemostasis, namely in the potassium channel, in the gap junction proteins, water channels, and sodium channels. There is also alteration in the gene expression of the immune response in the glial cells, in the astrocytes. And there is upregulation of the mTOR activity leading to increased excitation. These changes also occur in the surrounding tissue with activation of the adenosine kinase and increased transmission, in addition to the alteration of blood-brain barrier and local changes. This is a sum up. Limitation of the structural MRI in seeing cortical dysplasias. Maybe it's not enough to look at the MRI only to determine the extent of the lesion. Limitation of the scalp EEG in less than 50% it localizes, 70% in ictal EEG, scalp EEG. Data from intrinsic epileptogenicity, ECOG, shows that there is continuous spiking surrounding the glioneural tumors, and a removal of this lesion yields better surgical outcome, especially when we remove the extramarginal spikes. Ganglioma using ECOG shows lesional spiking 65% of those cases and has a better outcome. Now, more advanced neurophysiology, accentuated cortical evoked potential shows additional potentials outside the lesion. Removal gives you better surgical outcome. And the high frequency and low ictal slow shift, which is seen surrounding the lesions, give you better removal, gives you better outcome. The data also comes from the MEG that complete surgical resection of the tumor produce favorable outcome. So in conclusion, ganglioma is the most common tumor with intractable epilepsy. Extensive epilepsy surgery type is superior to laryngectomy in patients with low-grade primary brain tumors. Extensive resection is preferred with low-grade tumor, dual pathology, temporal lobe resection, and longer duration of epilepsy. Thank you very much.